So moving on to the GIT manifestations. So this is one of the earliest manifestations. So a child, a newborn baby does not pass meconium, and if you diagnose it as a Meconium Ileus, definitely rule out cystic fibrosis. So how does Meconium Ileus presents? So there will be distension, abdominal distension, child will be refusal to feed, there could be emesis and failure to pass meconium up to 48 hours. So based upon the radiographic finding and the clinical finding, we diagnose Meconium Ileus. So definitely rule out cystic fibrosis in any baby who has Meconium Ileus. So in case there is no Meconium Ileus, later on the child can present as. So of course meconium plug, meconium peritonitis, all these are newborn complications. Later on in older children, if you have a child with distal intestinal obstruction, intussusception and rectal prolapse again. So rectal prolapse, any child with rectal prolapse, we have to rule out cystic fibrosis. That is very, very important. Chronic pancreatitis children, of course, any child, it is very uncommon that the child comes only with GI manifestations, but some amount of mild respiratory system and there is some chronic pancreatitis manifestation, we have to rule out CF. And of course, I told you it can affect biliary system also. So primary biliary cirrhosis can be there, and whenever there is a chronic pancreatitis, all those pancreatic enzymes are not going to work. The child will be severely malnourished, and our fat soluble vitamins, that is vitamin A, D, E, K. So these fat soluble vitamin malabsorption will be present. So clinically you can see all these manifestations, bleeding manifestations, pallor, there could be hemolysis because of vitamin E deficiency. So all these, and of course the rickets-like complications. So these are all GI manifestations. Of course volvulus intussusception also happens, but they are not very specific for CF. Okay. So one is another entity in the newborn age, that is prolonged newborn jaundice, which is of obstructive pathology. Also we have to think of cystic fibrosis and cholelithiasis. Cystic fibrosis related diabetes, CFRD, is a complication for children with cystic fibrosis. I will talk about this, and initially they present as insulin resistance, but later on complete insulin deficiency will be there. So the patients will behave like a type 1 diabetes, so they need insulin also. Very, very rarely malignancies of the GI tract. So these are all the GI manifestations of children. So again this image will be helpful for you to recall all the GI manifestations in cystic fibrosis, starting from the gastroesophageal tract. So the GER can be there, CF related liver disease, that is prolonged newborn jaundice, biliary cirrhosis, pancreatitis, exocrine pancreatic insufficiency and late complication of cystic fibrosis related diabetes. There is Meconium Ileus, Meconium plug, Meconium peritonitis, and in older children distal intestinal obstruction syndrome. They have an increased risk of appendicitis, volvulus and intussusception. There can be constipation, and there is steatorrhea, that is passage of fat bulky stools, that is because of our pancreatic enzyme deficiency, and of course overall they will have fat soluble vitamin malabsorption. Okay, so this image you can remember. So this is a picture of Meconium Ileus, that's X-ray abdomen image of the Meconium Ileus baby. So here you can see that there is a hugely dilated bowel loops, and usually we say this is a soap bubble like appearance. Soap bubble like appearance that you can see here, because this is a soap bubble like appearance because of the impacted meconium. And this is the barium enema study. This is the colon of the baby. So look at the caliber of the colon, it is small. So this is a microcolon, and here you can see that there are filling defects, isn't it? So here there are filling defects, here there are some filling defects. All these are filled with meconium pellets. So that's why they look like there are filling defects in these children. So this is the image of Meconium Ileus child. Okay. So other manifestations will be salt losing states. So cystic fibrosis children usually manifest in summers because they might have a low level of pancreatic enzymes, and some amount of recurrent pneumonias would have been there, but otherwise they will go to the doctor, get treatment then and there, and during when the summer strikes high, these patients will lose a lot of water. So already they are losing salt and water, and they become very, very dehydrated, and this is the time when they come out and the diagnosis happens so much during summers. So they have a salt losing state and heat exhaustion. Even in some in mild summers also they will have heat exhaustion. Skeletal anomalies like hypertrophic pulmonary osteoarthropathy is seen. Clubbing, of course, because of the suppurative lung disease. Infertility in males, subfertility in females, delayed puberty can be there, and there is azoospermia, obstructive azoospermia 100% in all males, and females will be subfertile, but once they become pregnant it is tolerated. And CBAVD, that is congenital bilateral absence of vas difference. So CBAVD is also seen. And because of losing so much of proteins, they are edematous, hypoproteinemia is there, they are malnourished, and they are prone for amyloidosis also because of protein deposition. Aquagenic wrinkling is a screening test. So what we can see here is sometimes parents can themselves come and tell this history. That also happens. We have seen parents coming up telling that the child's palms become very much wrinkled even if they dip in the water for 1 minute, 2 minutes, etc. They will not tell you the minutes, but they will tell quickly than the rest of the children or rest of us. So aquagenic wrinkling or the palmoplantar keratoderma is a very, very inexpensive screening test that is done whenever you suspect a child of cystic fibrosis. This will not diagnose, this will not confirm the diagnosis, but it can be used as a screening test. Okay, I will explain about aquagenic wrinkling. So there is salt loss in skin. Okay, so we will see what happens in the sweat glands. So this is the CFTR protein which is present in the sweat ducts. Okay, so CFTR, what it will do? It will absorb the, this is the epithelial sodium channel. So there is sodium reabsorption is present. So from the lumen it goes into the interstitium. What happens? The CFTR protein in the sweat duct will absorb the chloride also. We saw in the respiratory epithelium, the chloride will be secreted. Okay, so basically this is a chloride channel which secretes chloride in the respiratory epithelium, but it absorbs chloride in the sweat duct. Normally in the interstitium of the sweat glands, so sodium and chloride will be present more than the lumen. Okay, what happens when the CFTR gene is mutated? This chloride channel is not going to function properly. So the chloride will not be absorbed into the interstitium. So this is going to stay here. So more and more, here the negative charge will become more and more. So to neutralize this, the sodium will also not get absorbed. This will also stay in the lumen itself. Okay. So we will see a lot of sodium chloride in the duct lumen when compared to the interstitium. So this is just the opposite of a normal sweat duct. All these are the sodium chloride. Okay. Sodium is in the green, small green circles, whereas chloride is in the small purple circles. So chloride is also getting absorbed, sodium is also getting reabsorbed. And so what happens in the interstitium, you will have so many sodium chloride molecules. If this is mutated, the chloride transport will not happen. So the chloride will be so much, so becomes chloride everywhere. So the negative charge increases. To neutralize, sodium will also stay here. So these two will bond and form so much of sodium chloride in the duct lumen. When you see in the interstitium, there is very less sodium chloride. Okay. So this is why when we do a sweat chloride level, these patients have very high chloride levels. Okay. So this is the function of, CFTR protein in the sweat ducts. Okay. So this is another tabular column representation of the clinical manifestations. We talked about what are the manifestations so far, isn't it? So respiratory tract manifestations, this is respiratory, this is GI, and this is other renal, endocrine, etc., isn't it? So what happens during each phase? So let's talk about infancy here. This is the childhood and this is the adolescence. So in infancy, initially it starts with infections. Yes, bronchiolitis. I told you, 80% of children with cystic fibrosis will definitely have one episode of bronchiolitis in infancy. So mostly it is infections. Coming to the gastrointestinal tract, even in fetal, if the bowel is echogenic, we will have to keep a high index of suspicion for these children. So this is an antenatal pointer. Right, fetal, I'll write it more clearly. So, presence of an echogenic bowel, antenatal pointer for cystic fibrosis. So other Meconium Ileus I told you, and meconium plug, meconium peritonitis, rectal prolapse and some amount of pancreatic insufficiency. So parents will tell that the child is passing large amount of bulky fat stools with offensive odor. So this history, all this will be present. Coming to the other presentation, dehydration of course. So even in mild summers they will become very dehydrated, and when you do the blood gas analysis, the typical blood gas analysis will be a metabolic alkalosis with hyponatremia and hypochloremia. Okay, so much of salt, that is sodium chloride, is getting excreted, is getting wasted through sweat. So what will be there inside the system will be less, isn't it? So there is hyponatremia, hypochloremia, there is metabolic alkalosis. So this happens in infancy. Coming to childhood, mostly all these respiratory infections will keep on going. So they will have acute exacerbations, and because of that patients will have complications like ABPA. There can be upper respiratory involvement like sinusitis and polyposis. Coming to gastrointestinal, I told you increased risk of appendicitis, volvulus, intersusception. There could be DIOS, and then primary biliary fibrosis and steatosis. So renal problems, renal calculi can be there, and again metabolic alkalosis can be seen. In older children, most of it what we have covered, ABPA will be there, they will have hemoptysis, recurrent pneumothorax will be seen in children with CF. So once they are admitted in pulmonology wards, you see these children will have like one cough and then they will end up in pneumothorax. So such is the recurrence of pneumothorax, and finally they will have respiratory failure. And very rarely these children can go for malignancies, GI malignancies like adenocarcinoma. In adolescence, in adulthood, the hormonal, that is endocrine complications like delayed puberty, the renal calculi, renal failures, clubbing, all these will be seen. Okay, so this you can remember. This is given in a image form in our Nelson textbook also. Okay, so this of course is a very important slide. So let's move on to how do we diagnose cystic fibrosis. So first is the sweat chloride test. So sweat chloride test is the gold standard for diagnosing cystic fibrosis. So traditionally it is done through the pilocarpine iontophoresis. So one is a positive electrode, another one is a negative electrode. So under these electrodes, one is, so we, through this pilocarpine iontophoresis, what we do, it is done under the forearm and we induce the sweating. Okay, so after 30 minutes of the procedure, the filter paper is taken and then it is analyzed. So usually it is done through filter paper, and sometimes even a tubing like a microduct tubing is also introduced. So that also we can collect the sweat and analyze. So the chloride analyzer will tell us how much is the sweat chloride level. There are very few genotypes which will give a normal sweat chloride, but maximum of them will have a high sweat chloride level. So when we interpret the sweat chloride level, that values will tell us how diagnostic the child, what diagnosis we can give. So in case it is more than 60 millimoles per liter, CF is very likely. Okay. If it is between 30 to 59, it is possible, it is intermediate, okay, it is possible, so we have to confirm it. If it is less than 30 millimoles, it is very unlikely. Okay, so this is the interpretation of sweat chloride. But sweat chloride is not 100% specific, and because it can have both false negative and false positive. Okay, so it's not 100% sensitive or specific, so we will see where all it can come false positive. Okay, so false positive means, here why we say that the sweat chloride level is high, because it is losing of so much of, the patients are losing so much of salt, that is sodium and chloride, in the ductal, that is sweat gland duct lumen, isn't it? Whenever there is an adrenocortical insufficiency, they will also lose so much of salt. They are also more prone for dehydration, isn't it? So some conditions, I will give you, there are lots of conditions for false positive sweat test, but I want you to remember around 5 to 6 conditions. One, of course, remember this adrenal insufficiency, pseudo-hypoaldosteronism, and any child who is malnourished, some skin conditions, atopic dermatitis, ectodermal dysplasias. Children with celiac disease also can have a false positive sweat test. So 5 to 6 conditions you can remember. Sometimes they say even in hypothyroidism it comes falsely positive. So these are all conditions which can cause a false positive sweat test. Similarly, there are some conditions which can cause a false negative sweat test in case the technique is wrong. Okay, we have not waited for 30 minutes to collect the sweat and there is insufficient sweat production is there during that time, and then some genotype I told you will cause a normal sweat chloride. So something like that could have been happened. So these are the causes for false negative sweat test. So this has to be interpretation of the sweat chloride has to be done based upon all these things in our back of the mind. Okay, so I want you to go through some of the videos. There is this video which is done at AIIMS Delhi. So this is a practical video which has demonstrated how they do the sweat chloride demonstration. So you can, in the official AIIMS website YouTube channel, you can see this is a beautiful video. So you can go through it, how they prepare the skin and how they place the electrodes, how long do they wait, and after that filter paper is taken from the patient's forearm, how do they prepare it and how do they analyze it. So everything will be demonstrated in detail. Please go through this. We will be able to understand how the sweat chloride test is done. Okay, and okay, so coming to the diagnostic criteria. So far we have seen clinical features of the cystic fibrosis. Now we will see how are we going to diagnose cystic fibrosis. So there is a diagnostic criteria. So in our country right now, we don't do a newborn screening for cystic fibrosis. Okay, so what happens is, what are the positive findings that we have? If there is sweat chloride analysis that can be done, usually it is done at least in 2 occasions. Okay, 1 occasion is not enough. Do it twice. So sweat chloride more than 60 on at least 2 occasions. That is enough to diagnose cystic fibrosis because that is the gold standard. In case we don't have the sweat chloride testing facility, we can do this, that is genetic sequencing. So if you identify 2 cystic fibrosis causing mutations, then it is positive. Or we don't have this also, then we can do an abnormal chloride transport, that is nasal potential difference. So transnasal potential difference is another one diagnostic modality. So if any of these are present with one of these, so you are going to do a sweat chloride test for a child who already has some typical finding. Okay, some recurrent pneumonia is there, failure to thrive, some pancreatic insufficiency. If there is a clinical feature which is typical of cystic fibrosis, in a child you do a sweat chloride 2 times, it is positive, then you give the diagnosis. Otherwise, if a sibling has cystic fibrosis and then you do a sweat chloride or you do genetic testing for that child, if it is positive, you give the diagnosis. Or in the positive newborn screening itself, it is coming positive, that IRT is coming positive, then you have to do any of these 3. Okay, so remember this diagnostic criteria, it is very, very, very important. So this is just an overall approach of cystic fibrosis. So in case you do a positive newborn screening or there is a clinical sign, clinical symptom which is suggestive of CF, ask a family history. Okay, then you go ahead and do a sweat chloride testing. Straight away 2 occasions sweat chloride, if you get more than 60, directly you can come and diagnose cystic fibrosis here without any confusion. In case you get an indeterminate value, that is between 30 to 59, you go ahead and do the genetic analysis. You get 2 CF mutations, CF causing gene mutations, then you can make the CF diagnosis. In case you get only 1 mutation or the genotype is undefined, then we have to go for additional testing. I told you about the transnasal potential difference. So you can do that, or an intestinal current measurement. So these are all advanced measurements which we do. So if it is present and if you have done it, it is becoming positive, then it is coming positive, then you diagnose. In case the testing is unavailable or it is equivocal, then you cannot make a diagnosis till the diagnosis of CF will become unresolved. In case the CFTR mutation if you have done this nasal potential difference and if you feel that it is negative, the test result is negative, CF is unlikely. Okay. And your genetic analysis also, if you have done that all the genes are normal, that you cannot identify a CFTR causing mutation, then also CF is unlikely. Your sweat chloride straight away it comes less than 29, then also CF is unlikely. But if sweat chloride comes negative, please do a CFTR gene causing mutation. Do the genetic analysis also, because I told you sweat chloride for false negative, we have certain set of conditions, right? So false negative there are. So we do a genetic test and then we can rule out. So this is the overall approach to any child with cystic fibrosis. So I talked about this aquagenic wrinkling test. So aquagenic wrinkling is basically an screening test, an inexpensive screening test. Okay, so initially what you do, this is the baseline. So the child's hands at start. 1 minute you immerse one hand alone in a water. Okay, in a standard tray you immerse for 1 minute, and you have to keep looking at the child's palms to check for wrinkling. Mostly these children, they develop wrinkling by 3 minutes. Okay, so the cutoff is kept as 3 minutes. If the child develops wrinkling within 3 minutes, then the screen is positive. Further, we have to go for diagnostic test. Sensitivity is around 81%. So this was published by the study from AIIMS in the year 2018. So in this study, the prevalence of aquagenic wrinkling in cystic fibrosis children was 95%. So the diagnostic yield is very, very high. And the median time to develop wrinkling in these children was 3 minutes. Okay, so sensitivity was really good. And children with CF who had delta F508 mutation, this is the most common mutation, isn't it? So children who had this mutation had lower time for wrinkling. Any other mutation apart from this had a higher time for wrinkling. Okay, so this is also a very good study, you can go through it. So aquagenic wrinkling test is a screening test for cystic fibrosis. Okay, so again this is another approach. So if sweat chloride test facility is available, you do this. If it is not available, what else we can do? So we can see this arm now. Okay, so previously one approach was when sweat chloride is present, you do sweat chloride, and if it is negative or if it is unequivocal, you go for genetic testing. If genetic is also equivocal, then you go for the physiological testing like transnasal potential difference, and you finally come to the diagnosis. In case sweat test is not available, I am not able to do a nasal potential difference, but there are so many other basic investigations that we can do, isn't it? You can do an ABG analysis, so hyponatremic, hypochloremic metabolic alkalosis. You do a serum sodium, you can find hyponatremia. You can do a stool for fat globules as a screening test, which will become positive. Sputum you can send if you can identify Pseudomonas, very, very high index for suspicion in these children. So in these, among these, so I have told almost, this is also an established approach. Okay, so acid base status, serum sodium, serum chloride, serum potassium, stool for fat globules, sputum or respiratory secretions for Pseudomonas. So these 6 criteria, isn't it? So among these 6 criteria, even if 2 abnormalities are present, you can diagnose as suspected case of cystic fibrosis and start the enzyme replacement. Okay, you are going to start the pancreatic enzyme replacement, and you can send the patient for tertiary centers who do sweat chloride levels, who do the transnasal potential difference or the genetic testing, etc. So, but do not wait. Okay, even if this basic test, I am sure every one of us can do. Even in a district level hospital, we do all this, isn't it? So you can definitely do these tests. Even if 2 abnormalities are present, start the enzyme replacement therapy. So that is what, so the Cystic Fibrosis Foundation of India. So I've seen so many talks from CMC Vellore, all the doyens of our professors, etc., who are propagating the cystic fibrosis treatment. So they have all told that this is an accepted approach. Even if more than 2 abnormalities are present, please start empirical pancreatic enzyme replacement, and if the Pseudomonas culture is positive, start antibiotics for them, start chest physiotherapy to enhance the mucociliary clearance. So all this is done. So once you are doing it, simultaneously you can ask send the patient for referral for a sweat test, for genetic testing, etc. Okay, so as long as you have done this, 2 abnormalities or more than 2 abnormalities are present, suspected case of cystic fibrosis, start pancreatic enzyme replacement. It is you are doing a very big thing for the patient. Okay, so till this we have seen about cystic fibrosis. Management part of cystic fibrosis I will deal in the next part. Thank you so much everyone for your patient listening.